Hey guys, we'll be getting started shortly. We're going to wait for a few more people to join. Thank you. All right, why don't we go ahead and get started? Why don't we get started with some introductions? So Dr. Hirschler over at Lakewood, would you like to not join, would you like to introduce yourself? Thank you.
Yes, hello, I'm Jeremy Hirschler, addiction psychiatrist over at the Lakewood Center in Cheat Lake.
I'm Philip West, clinical therapist here at Lakewood as well.
Perfect, thank you so much. Ryan, would you like to introduce yourself?
Hello, I'm Dr. Ryan Morrison at the Kanawha City Health Center in Charleston, West Virginia, Cabin Creek. And I have several of my staff with me I would like to introduce. So we have care manager Debbie Jones, nurse Catherine Darby, care manager Lois Vance, and nurse Janelle Artis.
Perfect. Thank you so much all for joining us. And Sue, would you like to introduce yourself? Oh, wait, sorry. Let me unmute you really quickly. All right, perfect. We can hear you now.
Sue Westfall, family physician. I'm at Cabin Creek at Dawes.
Perfect. Thank you so much. And everyone over at Trinity Family Healthcare?
Hunter Keister, I'm the case manager here at Trinity.
Thank you. And Sunny?
I'm Sunny Stanley over at Minnie Hamilton in Glenville. I have Laura with us, who's our case manager.
Perfect. Thank you so much. Alicia?
Hi, Alicia Heil, pharmacist with Rational Drug Therapy and the Safe and Effective Management of Pain program.
Thank you. And Audrey, are you able to use your audio?
Hi, I'm Audrey Hubbard. I'm a PA student with Shenandoah University.
Perfect, thank you. And Amy Lively?
I'm Amy Lively, care manager with the River Health Association.
Thank you for joining us. And C. Simpson?
Crystal and Heather from Camden Family Health.
Thank you so much. Angela, would you like to introduce yourself?
I'm Angela Barker. I'm the MAT provider at New River Health Association in Fayette County.
Perfect, thank you. And we have a Peacock.Brenda.
Hello, I'm Gail Peacock. I'm the Mother Baby Care Coordinator at Davis Medical Center in Elkins.
Perfect, thank you so much for joining us. And Beth Shelton. Why don't we go and do some of the phone numbers? We have a number ending in 3050.
Hi, yes, I'm April. I'm a peer recovery support specialist with Northwood Health Systems.
Perfect. Thank you for joining us. And a number ending in 6539. And a number ending in 4179.
Hi, this is Jennifer Boyd. I'm a physician assistant with New River Health Center, and in about a month I'll be starting the first MAT.
Yeah, perfect. Thank you so much. I'm glad the code worked and you can join us.
Thank you. I forgot to write it down. I'm glad to be here.
Yeah, that's perfect. Thank you. And why don't we start down here?
My name is Andrew Danko. I'm the program coordinator.
Megan Toscano, I'm the project assistant at WVU.
Hi, I'm Sheena Sayers. I'm the program manager for the MAD expansion project here.
Douglas Harvey, case manager for WVU Medicine.
Katie Chasson-Downs, clinical therapist for WVU Medicine.
I'm Mitra Motasham, project echo coordinator.
Tony Dikiakio, family nurse practitioner, WVU School of Nursing.
Right, perfect. So why don't we go ahead and get started? I'm so glad that's a huge turnout. So anytime you're ready, Ryan, I can pull up your case for you if you'd like. All right. Are you able to see that okay?
Yes.
Perfect.
All right. So this is a case. Let's see me. Yeah, this is a case I've actually presented this case before a few months ago, but it's morphed into something new, and we're bringing it back with new questions. Just to refresh your all's memory of the case of who it was. It was a 33-year-old male with a history of IV drug use associated endocarditis that I was hoping, actually recurrent IV drug use associated endocarditis of an aortic valve and Dacron mesh ascending aorta replacement. So my hope was, at the time, I was trying to come up with strategies to get him possibly sort of into a recovery mindset so that we could hopefully talk cardiothoracic surgery into doing something that they were refusing to do, a repeat valve in this person who's what we did not expect to get better with antibiotics alone with this infection of this prosthesis. The big question I have today, what's different than last time, is we sort of had taken him out of the main MAC group in regard with the recommendations we had last time. And we had tried to sort of, I don't know, almost call it hospice mat, because he refused to quit using, particularly meth, and he refused to go inpatient at WVU Morgantown, where we thought he'd have the best chance of getting cardiovascular surgeons to relook at this case. So what has happened is we put him in, like, we thought, well, why have him come every day here for ongoing use in the setting of a possible terminal valve infection? Why not just give him sort of a hospice mat that's not the standard mat protocol, where it just comes weekly? And we've tried this a few times since he's left, and we've had various problems with it. So this is sort of a patient that's not been getting treated according to the standard code protocols because he's sort of terminal. We tried one of the other things before anybody asks. We were advised to try to include his family in on this, to try to get his family to help to sort of leverage them, because he loves his son and his wife to go to the inpatient, but he wouldn't even let us meet with them or talk to them. So we never were able to leverage his family to get him to go inpatient. All right. So let's see where we are on this giant write-up I did. All right. So at this time, it's been several months. He's not gone back to cardiothoracic surgery after being refused for repeat repair. He has not taken the antibiotics or followed up with infectious disease that are recommended. And on his most recent visit with infectious disease, which we finally talked him into last week, they said that they didn't think he had the infection or that he'd be much sicker appearing, that he wasn't having fevers, but he still does have all the time spells of dizziness and feeling ill. But he also has Hep C that's very active, so that could be a contributor. But yeah, the ID doctor in his most recent visit, somewhat derailed our efforts to get him to go with a more intensive approach to his therapy, because they're saying, oh, we think you're just fine now. We don't think your prosthesis is even infected anymore. We think it just magically disappeared, the problem. At least that's what he says to us. We haven't got the notes from infectious disease yet. I don't think he made the whole thing up, but that's what he said. He's not been bad about lying to us. He's mostly told the truth that he's just using meth, but he has baited and switched us a bunch, where he said he would go to West Virginia University to go inpatient so that he could stop using methamphetamine, and then he doesn't go over and over. He's made us feel like he was going to go, and then it didn't go. And so I've basically I've got the situation where he comes sometimes for a PMAT and sometimes for I won't call it standard mat, but it's sort of solo hospice mat is what I call it. And we've been back and forth where he keeps asking for me to just let him not be in the intensive AP mat, even though he's still using all the time, and I can't really have him back with the other patients. He's still using meth. So, and I guess at one point over the holidays, I couldn't. He had failed a random drug screen when I had tried to take him to this standard, like this once a week mat, but then call him in for a random. He didn't respond to it, and that was actually the second time he had failed a random. The first time he said that his phone broke, and the second time I forget what he said. I think he said he didn't get the call. So anyway, so every time he's begging me, just let me come weekly and be solo in my hospice mat and just let me die from my infection whenever it kills me. And let me just keep using meth until I die and just take Suboxone and coming weekly. But then he can't do a random call in so that I can make sure that he's not just taking his Suboxone and selling it for meth. And so I make him come back 3 times a week. Well, at one point, I say, look, you're just going to have to quit the meth, or I'm not going to give you Suboxone anymore because I've got holidays coming up. I don't have any coverage to come in and give you medicine. No one's going to be here to do all the extra visits of coming every other day, and you're not responsive to randoms anyway. So I just feel like it's not, I can't have a good anti-diversion plan. So you're just gonna have to quit the methamphetamine. If you don't quit by next week, you're out. So we briefly suspended for holiday operations, but what happened for a few weeks? I mean, of course, he didn't stop using meth, and we actually just took him from AP mat to total discharge from the program, no medicine, with a tapering script. I actually gave him, I think I gave him 2 weeks of medicine just because I didn't plan to ever see him again. I figured that was just going to be, he was going to go die. But a few weeks went by, he's not dead. And holidays are over. So I said, and everyone's worried about him. Everybody likes this guy. He's a likable fella. People don't want him to die. They want me to do something to save him. So I bring him back, and he's right back in IOP again in no time. So in this section we're looking at now, it talks a lot about his remote drug use history. I'm not going to go too much into all of that. Basically, he's used everything, but nowadays he's basically just into methamphetamine and opioids. He got started with Percocets when he was like in his early 20s. He's like 33 now. So what I want to talk about, what's the crux of this case for me is most recently I tried to go back to the hospice MAT plan again prior to this infectious disease visit, and he felt a third unexpected random call-in. So, you know, I'm really frustrated that he can't make a unexpected random call-in, and you know, it's not evidence of well, it's circumstantial evidence for diversion, but it's not proof of diversion. And so I didn't have the heart to just toss him out over it, even though I'm very worried about diverting. He's just taking Suboxone, at least in part, and diverting it to meth. His lab screens always show bup, and nor-bup ratios are good. So if he is diverting it, he's diverting it very elegantly and difficult to catch way. He always brings back wrappers, or almost always brings back wrappers, although once or twice he's not been able to bring back wrappers. Yeah, what? Yeah, the stolen was his explanation for a random call-in, actually. So anyway, yeah, this is the most recent and third random failure. Is he had done his thing where he's like, "Why you can make me come every day, man? I'm dying here, doc. Let me just come once a week." So I let him come once a week, but I called him in for a random that very same week, and he didn't have his wrappers. He said they'd been stolen, so it was his third. He didn't file a police report, of course. It was his third fail, and so I said, "Look, I'm going to put you on daily witness-only medicine, except on the weekends, for now, because of all of this recurring evidence for possible diversion." He's on 16 milligrams, by the way, so that leaves me worried. So when we talk to WVU, we're going to go with what they say. Of course, it's been 2 weeks since I've had him on this daily deal, and he's already, pressure. We want you to let me go back to 3 times a week and then to weekly ASAP. So I'm sort of torn because it feels, in a way, pointless to make him come daily to get medicine. When he has every intention of just basically letting himself die if it comes to that. Even although I personally want to say the magic words that make him want to live, but I feel like at this point I've exhausted all of my ideas for magical words. So when I get there mentally, I think, well, 1 week at a time. My only problem with it is really the DEA concern of, if the DEA comes and looks at my records, am I going to have to live in shame if I let him go weekly, or 3 times a week with these continuously failed randoms? So I don't know if there's some sort of 3 strikes policy at WVU where you'll just say, you know what, 3 failed random call-ins, unexpected random call-ins equals you're just out of the program and we can't work with you. You have to go inpatient only. I know that if we do that, he'll just say, all right, I'm off to go die. And he really will do it. It's not just an empty bluff. So that's what really always stays my hand every time I think about taking the Stern road with him. So, yeah. So, so it's a very recent twist. So it occurred after we switched to daily dose witnessed only until WVU says otherwise. That infectious disease has said, you don't even have to worry about terminal disease anymore. I'm not sure how much I believe the infectious disease opinion. I think he probably does still have subacute bacterial endocarditis of a prosthetic valve. He's definitely used IV drugs since getting the valve. And so I don't want to take away his optimism though. So I'm just like, well, that's great news. And because I think maybe the optimism will help him want to stop using meth again. But it's not much. I think that the odds that he's going to discontinue meth is very low. Yeah, he's asked me to stop asking him if he used again because it makes him sad to think about the fact that he's going to continue to use and he doesn't plan to quit. So.
Yeah, thank you so much for that wonderful case. I wanted to ask everyone out there if you all had any comments or questions about this case in particular.
Ryan, does he like his life?
Yeah, he has kids. He has a kid that he loves. And he's got a wife that shares his addiction. I don't know. I don't think there's any way he could like it. He says he doesn't even get high on the meth anymore. He's not employed. He's been almost homeless repeatedly. He basically relies on the goodwill of others to house him and his family. So I'm going to go with a no, that he does not like his life.
I guess my feeling about why people take care of themselves medically boils down to whether they like their lives or not, or else they're so concerned about what terrible thing could befall them that would make their life worse. They'll take care of themselves to prevent that. And so he doesn't seem to fall into either category. Is he working with a therapist?
He is very avoidant. On multiple occasions, he's missed behavioral health individual appointments. I think he's only had a couple in the last 2 or 3 months. And no, the therapists feel that he is not really trying to let them in. I shouldn't say. I think he's Josh's, right?
Yeah.
Yeah. Okay. Yeah. Yeah. So Dr. Carter is his therapist, and I think he feels a bit defeated as well, although I don't want to speak for him.
Are there any other comments or questions out there? Did any of you guys have any comments or questions?
Yeah, Dr. Morrison, I appreciate you sharing this case, which is a very difficult case. And I hope that you recognize you have bent over backwards. You have tried, every aspect of treatment for this fellow. And you've been trying, again, you mentioned that this was a case that you presented to us months ago. That's how long you've been trying every option for this fellow. And I'm sure, my hope is that he appreciates that you have not given up on him.
I think he's very appreciative and he's very likable, but he would like to reduce his visits to us to just the absolute minimum and just have as much Suboxone as I'm willing to give him with as little therapy as possible.
I feel like I have a lot of patients who would like that option, so that sounds familiar. Yeah. Well, I love that he is not a coped patient. Is that fair to say? He's not somebody that that fits the model and is at a place in their life and their recovery that the model's going to really work for them. And so you have altered the model to try to meet him where he's at. And I think that says a lot about you. I think, I think you're just like he's got his boundaries. His boundary is he is not participating in his treatment the way you guys wanted him to initially, and that's okay to say. You also, as the provider, get to have your boundaries of if you want to receive treatment from us, this is what that's going to look like. I think that's okay to say.
I agree with Katie 100%, because you got to ask your question, is this patient in recovery or is this patient actually still in active use? And according to some of the comments you said, it doesn't sound like he's really working towards recovery. And sometimes the provider has to turn their recommendations into requirements in order to get that patient on the right track. So you've recommended and gave him the choice of going inpatient or to go see an endocarditis, cardiovascular appointment or infectious disease appointment, and he hasn't went to any of those because you gave him that choice. It might be that at the time in his treatment that you need to actually make that a requirement of his treatment. And if he can't do that, then you no longer can treat him. And if he wants to come back after so many days, then make that a requirement. In order for you to come back into our program, you have to complete a residential treatment facility. You have to go to these doctor's appointments for your health, because it sounds to me like his health is a big part of his recovery, and that might be leading into all of his relapses, depression, things like that, which doesn't want him to become sober.
Do you guys require?
I think now that he cannot go inpatient because infectious disease no longer supports endocarditis, we would be requiring just the other appointments, not inpatient anymore, because he may not even qualify for inpatient if nobody thinks he has endocarditis. I guess, would WVU be able to take him inpatient on just diagnosis of methamphetamine and opioid dependency?
Or the residential treatment facility would still take him as an inpatient.
Philly, you were going to ask something?
I was going to say, instead of, if you guys require meetings, you can always make doctor's appointments a requirement of that meetings if he's not really benefiting from attending self-help meetings or therapy. So really trying to meet the patient where he's at and say, listen, we know you got a lot going on, but we have to follow these set of guidelines. So you have to go to an infectious disease appointment or primary care or whoever he needs to actually see to truly rule out anything that might be contributing to all this.
Mm-hmm. Okay. Yeah, I like that.
So is there anybody with any firm feelings about the randoms thing? Like, when do we say, you know what, we don't care that you didn't get the phone call or that your medicines were stolen and you didn't tell us about it until we called you. This is too many failed randoms. DEA is not going to accept this. We have to treat this as diversion. Does anybody think that we've crossed that threshold?
So we would not give our patients 3 chances on a random call-in. Right now, personally, that to me seems like the least of your worries currently with all the other things this patient has going on that you need to make or I would recommend making requirements, because if he can focus on those and he can actually get to those other appointments or inpatient or residential treatment facility, whatever your recommendation is going to be, then hopefully he'll be able to get to those appointments and that will get him on the right path, which will probably also fix the random call-in issue and stuff like that. But to answer your questions, we would not give a patient 3 chances to come to a random call-in.
If they miss one, they have to check in regularly. If they miss the second one, they'd be referred to a higher level of care. And if they would miss the third one, they would be referred to a higher level of care outside of our clinic. And they wouldn't be able to come back until they've completed that higher level of care.
So I am investigating the possibility of potentially telling him, look, until you go to WVU for their residential, no more meds from me, then you'll be eligible after you've completed that. I thought that would be a very realistic possibility for what would be recommended today. But I'm also getting some feedback that maybe continuing on daily witness and having him start doing the doctor's visits as a part of his requirements is also reasonable. So I'm fine with either one. I would like some sort of consensus opinion now. Because I want to be able to put it down on paper that whatever I do was supported by WVU. That's
right. So I think it's whatever you feel comfortable with doing. Either way, whichever route you go with, I would definitely, instead of giving him the choice, make it a requirement and he has to do whatever you recommend, or you will no longer be able to treat him. And then if he wants to come back, he has to complete whatever that recommendation is in order to come back to your clinic.
Ryan, there is a literature on harm reduction, and this patient is kind of exhausting all the potential benefits of more intensive treatment. He just isn't receptive to that, And so if the DEA were going to argue with you about your care of the patient, you could say that he fits more of a harm reduction model. But the problem with somebody who's potentially diverting medication is that he's harming society, or so you might have to, if you can't show up for pill counts, then you probably can't give him the medicine, is my opinion.
So I will then, with that piece of advice, I will plan to tell him tomorrow that after speaking with WVU, he is to go. I can't give him the medicine anymore unless he goes and does a residential treatment with WVU. What do you
I
think
think
of
that sounds like a good plan, and you could let him know that you'll continue seeing him until he does that, and maybe have Lois or Debbie or somebody help get that facilitated to get him into the Center for Open Healing, and you'll treat him up until the day he goes, and then when he gets discharged, hopefully he'll want to come back. I don't think there's currently a wait list to get into the Center for Open Healing.
Anybody else on the call have thoughts about that? Would you do that differently if that was your patient you were presenting? Would you make a different decision at the end? How do you feel about Dr. Morrison's decision?
I do have a further refinement I just thought of I'm willing to, because this is going to just hit him all of a sudden tomorrow, where he's coming in daily. Tell him that I can give him a witnessed only through the end of the week. On Friday, I won't be here on the weekend, and there'd be no risk of diversion during the week with that until he could make arrangements to go up there. That would take away any potential for diversion.
Mm-hmm. Mm-hmm. Yeah. Were there any other comments or questions about this case?
Oh, this is Sue. I have a question about, you're only mentioning WVU. Is that the only appropriate option for inpatient for him?
We've had good luck with St. Francis in town. I would be fine with that if everyone else is. I think WVU is more appropriate for this patient, though, because of the potential for the endocarditis to be treated there.
That may be an area where you can give him some choices. Your choices for inpatient are, you have to make the choice to go, but your choices can be here or there, or.
And it seems like there's some hesitancy to just stop treating him. Maybe one option would be to, start the facilitation process for inpatient treatment. And then once the admission part comes, if he doesn't go, if he doesn't make that conscious choice, then at that point you stop treating him.
I have another question. So would it be okay to do kind of the harm reduction plan, even if he doesn't have endocarditis, if he were compliant with random call-ins and so on?
I think that's okay. I just wouldn't want him in a group setting where he's going to damage the treatment, the culture of the treatment program. So, but there's certainly a literature about harm reduction and reducing the likelihood of overdoses and, kind of the terrible lifestyle of someone who's actively using opiates. But you wouldn't want someone like that in your groups who's continuing to use and not working on recovery.
Dr. Hirschler, what did you think about the refinement I mentioned about the doing daily through the end of the week? Do you think I should just not even offer that, even though it does prevent diversion? Do you think I should say, look, immediately go? If you don't go, that's your choice, with no treatment until you return.
What I might do is get on the phone with the 2 rehabs and see when beds are available, and if he agrees to go, kind of do it as a therapy with the patient to actually work with him and getting the treatment scheduled. And then if he makes an agreement, then just treat him until it's time for him to go to the program. So even if it's a weekend and you have to give him medicine, it's better, at least you're treating him until he goes to the inpatient program.
I like the strategy. Dr. Carter did mention to me that we've already done this strategy, though. I wanted to point out that, like, earlier we did, whenever I said that for the holidays, we let him go. He actually went longer than he got medicine for, and he was supposed to go inpatient before he came back, but we didn't stick to our guns. We let him come back a bit after that, because he wasn't going inpatient, even if it meant dying. So I suspect this strategy implementation, practically what will happen, if history can be our guide, is we'll just be stuck on daily indefinitely while he continues to use and say that he's going to go to the hospital every weekend and not go, and he gets weekend meds.
Well, that's why it would be nice to do it with him and see what his bed date is, and then say, well, so we'll treat you until your bed date.
Mm-hmm.
Douglas, how firm are you on having openings up there?
Openings for, I'm pretty sure they have openings. The last I heard, and this was just a couple of weeks ago, that they did not have a wait list, that they had open beds.
Dr. Morrison's going to hold you to that if he calls tomorrow and there's a wait list.
Yeah, I'm pretty sure. And like Dr. Hirschler said, just continue seeing him, even if it is on a daily basis. Just don't give him the option to set this up, set it up for him and be like, this is the day, this is the time that you have to go for your intake to go residential. And we're going to continue seeing you, whether it's daily, every other day, weekly, whatever you're comfortable with, until that day. Then you have to complete this 28-day program or however long they keep him there in order to come back to our program. If you choose the route to stop coming to our program and not go inpatient, then that's your choice. However, in order for you to come back to our program, you have to complete a residential treatment facility in order to come back to us. And I would stick with that. And I know you said you let your guard down once for him and let him come back and whatnot, but obviously that didn't work either. So, you are the physician and these are your recommendations. So I would hold him accountable for that and not actually give him a choice. Other than if he chooses not to do your recommendations, then that's what he would need to do.
Is one of your concerns that he would then just say, well, I'm not going to go to inpatient, so I'll just leave you guys for 30 days and then come back like he did last time?
Yep, that's what he'll do. He'll milk it out as long as he can, and then he'll leave and he'll just take his chances with death. If he dies, he'll be fine with that. If he doesn't die, 30 days from now, he'll have not gone inpatient, and he'll ask if he's allowed to come back in. And at some point, 30, 60, 90, 6 months, it's hard to keep the guard up that you never went residential.
Yeah.
But I don't, I think we could 90 days or something. We could have like no readmission for 90 days without a residential, or I don't know how you would. But 30 days isn't enough. He will totally ride out the 30 days and not go. See if he lives.
Well, you already have a pattern here, so you got to expect it to try to crop up again. And so I agree with Douglas about being firm that he's not welcome back until he completes the rehab.
A permanent. 2 years from now, have you done rehab? Show me the records. You're not back. So I'm fine with that. I like that. I like that you said that, Dr. Hersher, because it gives me, I can just directly say what WVU's recommendations are.
He's failed this level of care, Ryan.
All right. Well, I really wanted to hear this so that I could be hard on him, because I don't have the heart to crush him and tell him, like, sorry, you can't manipulate me anymore. So having someone that I'm accountable to, that I can attribute this decision to, will help me.
The other,
he was, at one point he had almost 90 days sobriety and then returned to use, and this has just been ongoing since then.
the other piece to this is there a psychiatric component to what's going on with him? It's almost quasi-suicidal. I don't know. Maybe the severity of his infection of his heart valves isn't that bad, but assuming that it is significant and life-threatening, to do nothing about it and not be invested in moving toward treatment of it is passively suicidal. And has he had a psychiatric assessment? Is there a significant depression going on, or what's happening with that?
He has seen our psychiatrist, but I have not discussed what they talked about, so I don't know what happened there at that appointment.
Okay.
But my personal opinion is that he is just extremely apathetic. It's not really, it doesn't feel like a severe unipolar depression, but maybe that's because he's always on meth, and that's covering it up.
Sometimes someone who's using a stimulant may be self-medicating. So Kansian talked about the self-medication hypothesis and how people sometimes select drugs as a way of treating some underlying psychological symptoms. And so I wonder if he's chasing his depression with the methamphetamine. And I would talk to the psychiatrist and see what he thought. It wouldn't hurt to recommend that.
All right, well, thank you so much, Ryan, for that great case. I hate to cut it short, but we have just about 20 minutes, and I want to leave enough time for Katie's didactic. If there are any other questions, feel free to email me, and I'll make sure that they're addressed and back to you all. So anytime you're ready, I can pull up. Oh, sure. Didactic. Can you be the clicker for me? Sure, absolutely. I was going to ask you.
I struggle with the left hand that doesn't work. Thank you so much.
Yeah, of course.
So today I'm going to talk about social stigma, and then I think next month Laura Lander is going to kind of hone this discussion even more and talk specifically about stigma that takes place within our medical field with other providers. So I'm sort of starting the conversation about stigma today. Thanks so much for your time. Next page, please. So I know the folks on this call are really familiar with the diagnostic criteria for substance use disorder, but I included it here just as a reminder that when we can talk about addiction being a diagnosable and treatable medical condition, that can really begin the process of breaking down stigma, that addiction is in fact not a personal moral choice. So I'm not going to go over these with you. I know you guys already have them on there, but for me, it's just a good reminder as this is sometimes a starting place when I'm talking to folks out in the community. Next slide. Thank you, by the way. So here's another way to look at it that's helpful in the education process about the diagnosable disease nature of addiction. They fit into these 4 criteria. There's impaired control, risky use, social impairment, and pharmacological indicators. Again, those are just really helpful for me when I'm talking to folks out in community that are not familiar with substance use disorder to help break those down for them. Next slide. Thanks. So what's not included in the criteria that's helpful to go over with people, so for example, the type of substance used isn't included, and sometimes folks get tripped up on that. They think if there's a particular substance used, that automatically means that there must be an addiction there. Or to me, it's funny, the things in society that people accept and don't accept. I see folks in certain communities that are totally accepting of cocaine use, but not crack use, because that's where the stigma is. However, although it's the same thing. Quality of substance use, that's not on the list as well. Some folks can have a drink every single day with dinner, and that does not automatically mean that they fall in the criteria for substance use disorder. Frequency of substance used, whether the substance is legal or illegal, those are things I think folks, again, not knowing those diagnostic criteria, they think they're automatically at play with there, and they're not. They're still essential questions to ask, but they're not necessarily indicative of a substance use diagnosis. I like the quote, addiction is not what's in your bloodstream. It's more about how well or poorly you're functioning in your life as a result of what's in your bloodstream. Next slide, please. So what is stigma? Stigma is an attitude, behavior, or condition that is socially discrediting. Oftentimes the major influence regarding stigma with addiction are the beliefs about cause and controllability, our beliefs on what we think caused the addiction, and then what control the person has over it. I think that's where a lot of folks get tripped up. The words that we have used, the words we use have been shown by researchers to not only negatively influence our attitudes towards people in recovery and people who use substances, but they also impact access to healthcare and recovery outcomes. And research shows that addiction is the most stigmatized condition worldwide. It's still one of the few health conditions out there that some members of the public still consider a moral or criminal issue. Next slide. So stigma occurs at many levels, the public level, the private level, the personal level. People fail to access or engage in treatment because of the fear of what might people think, and so they don't want to be considered that negative word, that addict. The medical profession often fails to treat patients appropriately, like not using FDA-approved medications. Again, I think Laura's going to talk a little bit more about this next month. There's some mental health programs that still exclude substance use disorder patients. I'll hear that sometimes from therapists out in the community that they're willing to work with depression or anxiety or trauma, but not willing to work with addiction. And in this day and age, you just really can't divide those up. Funding for substance use disorder treatment is really insufficient to meet the demand. Folks that use drugs are viewed as unworthy of assistance, and public policies to assist them are often opposed. Stigma is structurally reinforced by laws that criminalize drug use and permit discrimination. We could probably have a whole series just on that. And if patients have a criminal history because of their drug use, then this causes future stigma in terms of employment, housing, and education loans. And so ultimately, stigma becomes a barrier to acknowledging the problem and then accessing that help and remaining in treatment. Okay. So one way we have the opportunity to address stigma in sort of a somewhat less direct way is really paying attention to the verbiage that we use when we're talking with folks about addiction. And that can be in something as formal as when we're giving a training or a presentation about addiction, but also when we're talking to folks about our job and what we do and the folks that we work with. When I first started working in this field, we still use terms like labeling somebody as an addict or a drug abuser. And in this day and age, we talk about statements like a person in active addiction or a person using substances. The concept of somebody being clean or dirty, we tried to take that out of our language here at the clinic a long time ago, and now it's more about somebody having a positive or negative urine. Replacement therapy, that's still a term that gets used with medication-assisted treatment, which is the, that's the statement we use about our treatment here. There's some folks, I talk with my patients about sort of how they want to educate other folks about what they're going through about their addiction and their recovery, and the differences in language when they identify themselves as somebody that's an addict and when they identify themselves as somebody that's a person in recovery. And of course, I never tell them what they should or shouldn't, how they should answer that for themselves, but to encourage them to explore that and what that would mean for them to change their own language about themselves. Next slide, please. So as helping professionals, we have the opportunity to help influence stigma in a lot of different ways. We can do that with our patients by helping them to reduce the guilt and shame that they're already feeling when they're coming into your doors, so the most compassion that we can give as much as possible. Offering moral support, offering that helping hand. That's why I have a picture of my pigs with my farm. Seemed like I was offering them a helping hand. Doesn't really look like that now. Respecting their confidentiality all of the time. Adopting a non-judgmental yet accountable stance with them, and then treating the patient like any other patient with their chronic illness. Dr. Morrison, I think you gave a great example of the fourth dot, adopting a non-judgmental yet accountable stance with the patient that you're talking about today. You clearly care about him, and you're trying not to judge him for the space that he's in, but you want to figure out how to hold him accountable to that. We also have the opportunity to help influence stigma with the public and ourselves by providing education about substance use disorder being a disease and never stop talking about that. And then also sharing stories of success. I always have the argument that sometimes the news and social media drives me crazy because we only see the mugshots of celebrities in the news, and we only see when our patients have been arrested for something that they've done. We don't see news articles about so-and-so celebrated so many years of recovery today, or so-and-so gave their first lead today, or so-and-so did this. We're gonna have to be the ones to do that. We're gonna have to be the ones that are going out and talking about all the countless sort of positive stories that take place from recovery. And then we're always going to have stigma ourselves, and that's okay to admit. So being aware of your own biases, you know, and making sure you're getting support from that, if that's from your colleagues, if that's from supervision or consultation groups, if that's from echo calls, working to change our language over time. I still sort of catch myself maybe using an old verbiage I would have used, and I need to hold myself accountable and work on that. And then finding for support for any kind of transferent issues we face. Next slide. And so I want to hear from you guys. What have you found to be kind of the most effective way in addressing stigma, if that's amongst patients, if that's among folks in your smaller community, your greater community, yourselves? What has worked for you guys?
I'll give it a go. So I think it's important for patients not to settle for a stunted identity. And so, you know, if they have kind of negative views of themselves based on how society views something they're doing, I think that's damaging to their health and to their success and quality of life. And so I encourage patients to think about what their positive qualities are and build their identity around things they're trying to improve to better themselves and who they're becoming, while they also have some strengths and positive qualities. I think it's important not to settle for a stunted identity.
Love that. Yeah, absolutely. Thank you, Dr. Hirschler. What else?
We've been doing, it's just a series of lectures for our residents and different staff, identifying what stigma actually looks like. Because a lot of times I think they think it's just, oh, that addict or that person, but it's more so how we think, how we present a case, how we describe a person with substance use disorder versus that addict who keeps coming back time and time again. So we've been doing a lot of that and of trying to catch ourselves and make ourselves more mindful of the verbiage we use. So that's we're starting to get make some headways, because now at least we see some people like saying, oops, I shouldn't have said that, I mean this.
Yeah. I love that. That's great work. Who else? What else? You're also probably doing more than you're currently giving yourselves credit for. If you've got programs up and running in smaller parts of West Virginia, and that can't be easy. And if you still have your doors open, you guys are doing something good and not giving yourselves credit for it.
I'd like to share my newest strategy that I think is going to be effective, more effective than presenting science, which I've made the mistake of doing too many times. Is try to get someone to imagine, someone being their son or their spouse as a victim of stigma. Doing a little bit of an exercise with, like, imagine your own son is the one who's just had a heroin overdose, and the paramedic is tired of dealing with him, and he says, "Leave him while I let him die." And imagine how that would make you feel. And I think these powerful images of stigma, if you can put them into the context of it affecting someone you know and love, that it can help you to start to realize how horrible of an impact it has.
Yeah. Oh, that's a great strategy, Dr. Morrison. I think I just have one slide left. So I would imagine most of us know by now that we have the potential to be so much more effective with our patients when we're coming from a compassionate, empathetic place. And so similarly, we have the potential to be so much more impactful with folks in the community when we come to them from a place from compassion and empathy. You know, I know I can remember in times in my past when I was trying to force somebody to understand addiction or to shame them into becoming tolerant. And what I was doing was exactly what I didn't like that they were doing, which was being intolerant. And that's not going to work, and that's not going to be respectful of their own journey. So we have to remember that sometimes we're going to be meeting people who have been burned by addiction in the past. And I think it's helpful to be empathetic to them of that. And again, to provide education as much as possible and in ways that can help them look at it from a different perspective. Dr. Morrison gave a great example of that. And then so I like this quote. This quote came from Daniel Raymond. He's the policy director for the Harm Reduction Coalition. He said, when he's talking about patients, he would say, rather than getting angry at people who use drugs because they don't do what we want them to do, let's try and understand why they do what they do and work with that. And so the flip side of that for the folks in society that are struggling to understand addiction, how do we understand why folks in society have such strong stigma views about addiction, and then meet them where they're at and work with that. And I think I have one more slide.
Oh. Thank you so much for that.
Yeah.
That was really wonderful. Did anyone have any questions about the didactic? You know, we talked a little bit through it, and you made it really interactive, which was great. But if anyone has any other questions or comments?
I did have one. So one of the things Ryan spoke about was him not coming in for his random counts, yeah? So we have similar issues, but just in general and with the lack of transportation, because some people come from 2 hours away, 1 hour away. And frankly, I had someone today who has been doing well for 315 days, and she relapsed over the weekend. And so we had a discussion, well, I'm going to move you up to a higher level of care. We want to make sure it gets you back in the right track. And, you know, I'd like to see you in about 2 weeks, right? Well, she goes, well, Dr. Bo, I have no way of getting there. I don't own a car. Logistic care doesn't come out to this area. And I'm thinking, man, I can't wait for Echo to go trouble solve. Yeah, so, I mean, Doug, what have you all been doing? I know you all have different resources than we do. What should I do about that?
Sure. So, so was this one of your patients in one of your monthly groups?
Yeah.
So typically if our patient relapses one time in a monthly group, we'll leave them stay in that monthly group.
Okay.
Hopefully they'll get back on track, but if they continue to relapse, then we will do what you suggested to this patient, start seeing them more often. So in this case, every 2 weeks. And if the patient gives some pushback on that, we would be very firm with that and say, you know, this is our recommendations and this is what we want you to do for your recovery treatment, and you will need to come back every 2 weeks.
Okay, because what I've been doing this year is trying to really enforce the group attendance, like the recovery attendance. And what we've done, we've actually started a recovery group before our group. So whoever patient comes, patient there adds it. But for some people, that's the only group they can come to outside of our group because of transportation issues. There's even some people have no Wi-Fi. So I'm like, man, I mean, how can I go about enforcing this when I know that there is nothing in their community? They also live far away, and they also legit don't have Wi-Fi.
So I think that's a good question to ask some of the other facilities on the panel, because I know there's several familiar facilities and maybe what they do in these circumstances.
Especially the rural places.
So her general question was, so for the COAT program, we require 4 hours worth of recovery meetings per week. And she has some patients come from very rural areas that there aren't meetings in, and they don't have internet to do one online meeting per week. So she's wondering what anybody else on the call might do if they have the COAT program in their facility to help patients get to 4 hours worth of recovery meetings.
At our Cabin Creek clinic, we have a 12-step meeting following our behavioral health and our medical meeting, and we count that for more than one. We count that for 3, and then we count their doctor's appointments, volunteering, and a job.
I also had one question come in through chat. We're right towards the end of the session, but I can quickly ask it. Or let's see. Oh, thank you, Dr. Morrison, for answering that. So the question was regarding a patient who was an intake for MAT, and they just received Sublocade, 300 milligrams last week, also on 12 milligrams of Suboxone daily. Is that normal? And so Dr. Morrison responded saying, sounds like some expensive, doubt insurance will pay for. I'm told it's roughly 8 milligrams daily Suboxone. So I don't know if anyone had any comments about that.
I think I under. Go ahead.
It was
Sorry.
one patient, sorry.
Okay.
They were from Illinois. Oh, yeah, that's gonna not work well. They were from Illinois, and it's still not working.
You sound cool though.
Okay. We're hooked up to 2 computers, so the patient in Illinois, and so he was at a recovery center in Illinois, and that's how they had started him on. He said Sublocade, 300 milligrams. He had it last week, and he was getting 12 milligrams of Suboxone on top of that, in addition to the Sublocade. So I am not familiar with Sublocade. I didn't know if there was like a tapering dose, like for a limited period of time until the patient was stable on the Sublocade, or how that worked. So
Yeah, from my understanding, it should definitely be one or the other, not both of them at the same
that's what I was thinking.
Yeah.
Yeah, for some people, near the end of their 28 days, they start to run out. And you need like 3 or 4 days, but you can give some Suboxone or Subutex to them. But in general, once you have 300 milligrams, all those receptors are blocked. That extra 12 is not doing anything. It's not binding anywhere. Maybe he's telling, I don't know.
He was also on 900 milligrams of Neurontin 3 times a day.
Does he have peripheral neuropathy? Is he diabetic?
No. I didn't prescribe anything to him today, so just my I was like, I'm gonna have to talk to my peers and I'll get back to you. But I don't think that's gonna happen.
Yeah.
So yeah, he said it was for his anxiety. He said his anxiety is so severe he wouldn't be able to be there to even do the interview today if he wasn't on his medication and stuff like that. So, and he was from Illinois. I couldn't look him up on the Board of Pharmacy. I did have his discharge papers from the rehab though, where he was on so the Suboxone, 12 milligrams, and the Neurontin, but it didn't have the Sublocade on there, and I didn't know if that was error, and I haven't got a chance to actually call the rehab center yet or anything. So,
Great question.
Yeah.
Thank you.
So Dr. Bo, just really quick to go back to the recovery meeting issue that you're running into. So another thought that you could do is actually maybe see this patient on an individual basis outside of your COAT model. Because if you adjust meetings for this specific patient, then you're going to have to adjust meetings for all the patients in your current program. So something that you could do is if this person's doing really well and so forth and honestly cannot get to recovery meetings, see them on a one-on-one basis and maybe not even require them to do meetings, just do 1 a week if possible or something like that outside of the actual COAT clinic that you're providing.
Another question. It's past 5. I can text you this.
That's fine.
We can also talk at the next hub call about how, what have folks done to get creative to get their folks into meetings in some of these rural areas, how to help them start meetings there, how to help them celebrate recovery meetings at their churches, how to help them bring because if they're needing those resources, chances are there's other folks in town that need them.
Yeah, I mean, they pretty much say they all use together that at least 10 people will love to go to a meeting. They just don't have a place where. And I don't know how to go about contacting a church so we can start set one up.
Sure. So that can be a thing that we talk through on the calls is how do we help our patients start up a meeting?
Great idea. And if there are any other questions, you guys can all email me and I'll make sure to have them addressed. So one quick announcement before we do end the session. The next session is on February 24th and Sheena and Douglas are going to provide our didactic on MAT expansion. So I hope you all can join us for that as well. Thank you all so much for coming to this one and keep an eye out for the recap email tomorrow. Thanks, guys.
Thank you.
Bye.
Bye.